so we will get started. I will now. Can everyone see me, or do you all see Ali? Caroline, can you see me and can you hear me?
Yes, I can see you and hear you. Ali's
fantastic. Yep. All right. So welcome everyone to today's session. So for today's session, we're talking about module 2 of the CHAP manual. So this is a focus on the early stage of cardiac rehab. And so it's the point just following the first module, which was about the assessment. So just to introduce you to our speakers for today. So we have 2 speakers joining us today. And so we have Ali, who will introduce herself, but just to give you the overview. So we have Ali, who is going to give us a patient perspective on her experience with rehab. And then we have Caroline, who's going to give us a clinician perspective of this stage of clinical rehab. Now, for Caroline, I have some specific questions, but for Ali, we're going to just let her jibe and say whatever she wants to cover. And how we're going to run this is we'll have Ali give her a discussion first, and then we'll break for 5 minutes or so of question time, come back and hear from Caroline, and then make sure that we save at least 5 minutes for question time afterwards. If you do want to ask questions throughout the presentations, feel free to drop them in the message bank and I can read them out loud, or put your hand up and I'll know to ask you about your question. So after we've gotten through everyone, just so that you don't all dash off at the end, I just want to say, have you guys heard about our video wall? We're creating a video wall to go on the CHAP website, and it's going to be just a little short videos, maybe 10-second videos, where we get clinicians to say things like, my name is Stephanie Champion, I am I'm a cardiac researcher, and I recommend cardiac rehabilitation for all eligible patients. We'd love to get some recordings from you guys. If you have a few minutes to spare at the end of the session, just hang around and we can do a quick recording if you're happy to give us a little spiel to add to our wall. So we can just get started, and I'll hand over to Ali. And all I'm going to do first off is move our camera to show you that there are actually more people in this room.
Hi, everyone.
There we go.
Hi. Just before we start, I'd like to acknowledge the Aboriginal and Torres Strait Islander First Nations people as the traditional owners of the land on which we meet, and acknowledge their spiritual, cultural connections to land, water and community. And I pay my respects to the elders of this country, both past and present, and Aboriginal peoples who may be present in this gathering. I am a person who had some very risky behaviours in my younger days, up until I was about 54 years old, at which point I had a heart attack. So not only did I have risk behaviours myself, I ate too much, I was very overweight, I smoked and I drank, but I also had a lot of hereditary input from all streams of my family regarding cardiac risks. So my mother also had a heart attack at 55. So you would think that, you know, one would actually have learned something from all that, but no, didn't. So at 54, I had a heart attack. I had 99% stenosis of my right distal coronary artery on the first right posterolateral branch. There you go. But I also had 85% stenosis of my left anterior descending, which was later treated in a readmission, planned readmission. So it's a bit of a shock going through having a heart attack. And in fact, I wasn't sure that that's what was happening to me. I was in the pool doing a PT session. But my PT, my personal trainer, had to jump in the pool and help me out of the pool, and they called an ambulance. I was taken to Anguston Hospital and then on to the Lowell McEwen, where I had angioplasty, stents inserted overnight, and then was in hospital there for, I think it was a day and a half after that. During that time in hospital, I was actually given a lot of information. So people would talk to me about what was happening. There was diagrams up on the board in my hospital room that said LAD and other things that didn't actually mean anything to me. I was given the my Heart, My Life book from Heart Foundation to look at while I was in there, contemplating my navel and resting up. And then the day or the morning that I was to be discharged, I had a cardiologist came and sat on my bed, and she went through a raft of information, gave me a bag of drugs and organised for me to go down and see the pharmacist, who then spent another half an hour with me going through I think it was 5 drugs, extra drugs that they'd given me. And then I was out the door with a pamphlet that was my discharge pamphlet. It wasn't actually the discharge information about what had happened to me or what was expected to happen over the coming days, or the information that would go to my GP. It was a pamphlet that gave a rough idea on what I should be looking for over the next couple of days. And it covered a number of different cardiac events. So it wasn't just the ones that I was actually experiencing. It also didn't have any contact information for my local GP or for my cardiologist. So that was kind of interesting. So I didn't know who to contact. Well, I knew who to contact as far as my GP went, but not my cardiologist. I stayed at my sister's place in Adelaide for 2 days while things settled. And then went home to my, where I was living at the time, which was Tanunda, where I live alone. And my sisters insisted that I make sure I have my phone with me at all times there for a while, so that if I should happen to have another heart attack or something happen, then I could at least get contact. I think it was within the first 48 hours, 24 to 48 hours, that I got a call from the unit that organises the rehab, and they asked me whether I would like to do physical rehab, so go to a place and engage with other people, or whether I would like to do catch. Of course, being a reasonably busy person, working in the primary health network, but also as we were funding catch at the time and still are at the moment, I was actually really keen to see how catch would work as a rehab mechanism. So you might understand from my tone then that in actual fact, one of my coping mechanisms on coming out of hospital was to intellectualize a lot of the things that were happening to me, and not relating them to myself personally, but actually to how rehab and cardiac might affect a patient from an academic point of view or a planning point of view. So that was kind of a little bit different. I did see my doctor within 7 days. He was very surprised that I'd had a heart attack. He hadn't looked at or seen my discharge information. It had come through to the surgery, but I don't know who looks at those things when they come through. And then within 14 days of my heart attack, I then started my rehabilitation. And one of the things that I discussed at the last session when I was asked to talk about my experience with having a heart attack was what actually happens in your head, or for yourself as a person who's had an event and has been in hospital. What happens to you and your thinking when you get discharged? And probably over the first, whilst you're in hospital, but over the first 24 to 48 hours, it is actually, it's quite a shock to your system, and trying to take on board large bites of information is actually really difficult. So some of the information that the cardiologist and the pharmacist gave me when I was being discharged from hospital just went straight over my head. It went in one ear and out the other. I didn't take that on board, and felt, I guess by the time I got home, I felt a little at sea, in that I really didn't understand a lot of things. I know I had got out my Heart, My Life book again, but it still seemed a little disconnected from me. So it wasn't really until I saw my GP, that was okay. That was kind of bringing me down to earth a little bit. But it wasn't really until I started doing rehab that I really started to connect with what was happening. And again, I did intellectualize it a little bit, and I think it took us a couple of sessions for me to admit that that's what was happening, for me to then engage truly in what we were looking for from rehab, which was to actually make sure that I was understanding what really was happening to me, why it had happened to me, and how I could actually change my behaviours in order for it not to happen again, which was kind of the crux of the thing. I did a huge amount of questioning. I had a great coach in Jacinta, in that if I asked something and she didn't have it quite there, she would go looking for it. More often than not, the information that I was seeking and that she was giving me, she had on hand on her fingertips, and quite often it was actually in the My Heart, My Life book. But it's actually trying to engage your mind so that you're making sense of what this information is and how it actually relates to you as a person. I know that different people experience this in different ways. So I was very grateful to Jacinta's perseverance with me. I'm sure that I was pretty annoying at times. At one point I was questioning her massively about, really, what is it about cigarettes that affects the arteries? The information just isn't there. It's like, when you're looking at the ads and the information that is, on the top level at quit smoking, it gives you that, okay, yeah, it's going to affect you. It's going to affect your arteries. But why does it do that? What is it behind that? So it's about the inflammation. So getting a little bit more of in-depth information about what it is that really does cause some of these things, and what it is that, when you change those habits and behaviours, that actually really makes the difference. So a big part of it is that being able to connect and take people through the behavioural change and why they should do it. So, talk to, part of it was talking to a dietitian, and, how many times have I been to a dietitian? I was really overweight. My BMI was 40.23. So, I was 106 kilos, really, really shocking. But until you are engaged yourself personally and psychologically to make that change, you can do a lot of talking and it doesn't happen. It becomes very difficult. So part of that whole rehab thing was taking and guiding me on a journey to actually even make minute changes. And I think that was kind of quite a big thing for me. I didn't stop smoking during rehab, but I did cut down massively. I don't smoke anymore, by the way, and I haven't for 4 years or so now. But so it's giving that information and understanding when you have connected with your consumer or patient or whatever you like to call them, because unless you understand that you've actually made that connection, you can keep on, the patient can keep on saying, yes, I got that, but in actual fact, they may not have. They're just giving you what you want to hear, not what they actually need to do. And I know that I've done that myself. So it's a really tricky thing, but it is part of that connection with your consumer. Part of it is about understanding how I, as the patient, might make a decision. How does that impact on the whole rehab process? I think I got to a point with Jacinta that I could actually put things to her that I was thinking of doing, and just to get a little bit of an understanding as to whether that might help or might not help. And it wasn't necessarily that she actually took control. It was actually that she was there to provide some guidance and to kind of help me on the way. So the whole, and I guess that's part of that coaching side of things. I think that probably I could have had rehabilitation for another 2 years. But that's not how it works. We do have, it does take a reasonable amount of time to really change your habits and change your life. And sometimes, you've only got this piece of work that's, with Catch, it's like 6 months, and then it's got this many sessions, and then it slows down, and then it's the 12-month one, and then it's gone. Sometimes we need a little bit more than that. Sometimes we don't need that much of it. So it's what is it that as a patient you might need?
Yeah,
but also,
yeah, you've picked up on something really important there, and I want to ask a question about it, but I do wonder, does anyone have any questions so far? Anything they want to put to Ali about her experience or your experiences as a clinician delivering this early stage? So, because I think one of the things you were talking about there was about how they convinced, how you move from that intellectualizing to making proactive changes in your life, even though it was a long process, and things like quitting smoking, congratulations, it's not going to happen overnight. So I have a question about that, but did anyone else want to put a question to Ali?
And please feel free to ask personal questions. I don't have a problem with that.
Yeah, you've shared quite a lot of your experience with us before, so you're an open book at this point.
Did you ask Ellie how she dealt with the bag of drugs?
Oh, yeah. So we have a question from Robin, and Robin's asking how you coped with the bag of drugs that you were given when you were sent on your way with your pamphlet.
It was the very fact that they gave me a four-page document to go with that. So they'd actually printed out what the drug was, what it was supposed to tackle as far as my cardiac condition went, and how often I needed to take it and when I needed to take it. So there was actually quite a bit of instructions there. So whilst the pharmacist, you know, tried to give me the information that I needed, it was actually that 4-page document on all of my drugs that actually was the thing that got me past my first day.
Yeah. Yeah.
Because it was a lot of drugs to take. They were, you know, I was used to taking drugs, but mostly they were at the beginning of the day, whereas this was different drugs at different times of the day, 2 here, 1 there, you know, all over the place. So it was a lot to cope with to start off with. But one of the things that I guess I took away from it was that, you know, I was not necessarily going to be on most of those drugs for very long. So that was kind of like a big thing.
So you could cope with it for as long as it was going to take to get through that bit. And and I think the way you talked about the drugs there, when you said that it was a set of instructions, did you ever get someone to explain to you why you were taking those particular drugs, or why they had to be taken the way the instructions detailed that they had to be taken?
So I had a pharmacist. It was part of my catch program. But also, I think amongst the early parts of the work with Jacinta was around, you know, what do I understand from my drugs? So she did take me through a lot of that. You know, I still go, somebody will say, well, why are you taking this? And I go, I don't know.
I was told to, and I did it.
It was one of those things that I didn't necessarily really crunch into my head for some reason. I've been taking drugs for a very long time. I have psoriatic arthritis. I've had high blood pressure, cholesterol, and depression for many, many years, since I was about 36. So, you know, about 20 odd years. So I have been, you know, stuffing things in my mouth for quite some time. I do know what those drugs do. Mm-hmm. So when I have this other big lot of drugs come into my box, and it did increase to a box. It used to be a bag. Did increase to a box. A couple of them I knew fairly well what they would do. Mm-hmm. A couple of others, I kind of, you know, went, okay, yeah, I think that might be an anticoagulant. But I couldn't swear by that. So I guess one of the things that I take from that is, apart from the fact that knowing that I may not be on these drugs for a long time, is that actually that's quite an important part of understanding your condition. So knowing that the diltiazem, you'll be on that for this length of time, and some of the other ones a much shorter length of time as your heart, blood vessels, or arteries heal and clear. So it's kind of like, yeah, maybe a little bit more needs to be spent on that. But to watch, I think some of the other things, it depends on.
Yeah, it's very has to be very patient.
It depends on the person.
Yeah.
and what's happening with them. I think mine was fairly straightforward. I wasn't a complicated patient. I did have a blockage. Well, I had 2 blockages. They both were resolved by stents. I loved my kissing stents, and my left was a LAD. But the drugs got me through that next lot, and I'm out the other side. There's always a risk that I will have another heart attack. What I'm more worried about these days is, will I have a stroke? So there's the other side of it, that when you have what is it called, the narrowing arteries, when that occurs, if it's occurring around the heart, there's a likelihood that it may be occurring elsewhere. And I did have a little episode about a month after my heart attack, and which took me off to hospital to have an MRI, and they found some narrowed arteries up here, just a couple. And that was about, okay, so I need to really it just brings it home that I really need to get my cholesterol down. I need to really work on that exercise. And, so it's, why am I doing these things that I need to do, which actually helps the blood to pump better around my body, to get rid of that fat where it shouldn't be, and any of the buildups. So there's kind of if you can relate it to one thing, it's going to be related to another thing that may happen in your body as a result.
So it would be scary to have that information.
Yeah, look, I have strokes in my family. Also, one of the things that I said to the anaesthetist when he came through prior to getting my stents done was that, he said that there was a risk of stroke, of something being dislodged and having a stroke. And I said, do not resuscitate me if I have stroke. He was a bit surprised by that, but I've got really big lots of stroke in my family, and I don't want that. So it's just kind of like,
And you had that clarity, like you knew.
Yep.
All right. So thank you, Ali. Sorry to cut you off. 45 minutes is not long enough. We will move over to Caroline. Caroline's having a few connectivity issues, so we'll see how we go. Are you still with us, Caroline?
I am. Can you see me?
Fantastic. Yep.
Can I just, Caroline, before you start, can I just say one more small thing? And we were talking about this before. As a patient, I think I've been particularly lucky in that I've been able to access through the Catch program a lot of the information that patients actually aren't normally given. So I've got the pictures of my heart when it was having the stents done, or post and pre-stents being done. I've got the pictures, I've got the information. It actually makes me feel more empowered and knowledgeable about my condition than that vague information that I got when I left hospital.
Yes, thank you, Ali. Yeah, thank you, Kat.
I'll be quiet now.
So we're doing it a little differently with Caroline. I have 4 questions for Caroline, but we're going to see how we go. And I will just bring them up. So the first question I had for Caroline was about the advice that she gives to patients around creating an action plan. So the module and the My Heart booklets talk about action plans. Is this helpful for patients to have? Is it easy for them to create one?
Thank you. So firstly, thanks for inviting me to speak, and thank you, Ali. I could listen to you all day long. Your journey and sharing that is really powerful for all of us. Fantastic, thank you. And firstly, also like to say too, there's a lot of people I can see online who've been in the field of cardiac rehab for as long as I have, or even longer. So I'm just really going to talk about my experience, and I'd hope that you'd be able to add some bits to the discussion as well. I guess on the topic of the module and action plans, having looked at the module, you know, there's so much information that as a clinician you're trying to get across to the clients, consumers. That is certainly not what I'd want to present in one session. And then also it's really going to depend on whether you're doing a group-based program or whether you're able to be working one-on-one with someone. When I think of action plans, I think of a clinical action plan, firstly, warning signs of a heart attack, what I need people to know that they're going to get the quick treatment that they need, or whether they've got angina and how they're going to respond to that. So that's the first thing I think of when someone says action plans. I'm really thinking of those clinical action plans. And because in cardiac rehab in country, you know, we include heart failure clients, AF clients, you know, the action plan that's of a clinical nature might be quite different depending on the client's condition. When I think of individual action plans that might be meaningful to consumers, I'm thinking about lifestyle change. And it's not usually something that I would help someone sit down and work through at the early stages of their cardiac rehab program. It's so many variables, and a one size fits all doesn't fit anyone in this setting, as we all know. So it really depends on, you know, how long has it been since they've had their cardiac event, willingness or readiness to change, as Ali mentioned, really is a huge factor in setting a lifestyle plan of change. So I tend to be quite, I guess, flexible and adaptable to the cues the individual might be giving me in terms of whether this is something that's going to work for them. People that are highly motivated usually come to me with my heart, my life, and back on the end of the booklet, take action, they've already filled it out. That's a highly motivated individual with good health literacy. And those people, obviously, you're just going to encourage and, you know, let them know they're on the right track, but that doesn't fit everybody. And in fact, some people that I've had, even working one-on-one, we never get to that stage where they're going to set, you know, a lifestyle action plan of change, because there's too many things affecting their life that are taking energies elsewhere and they're just not ready for it. Does that sort of cover that one, Steph?
Yeah, do we have a question from the room? Yeah? No. And I think that was something that we heard from some clients a couple of weeks ago. We heard from some patients, and they talked about being ready to set goals. And so this is sort of an extension of the action plan question, but patients are guided to set personal goals from the beginning of their rehab. Is this realistic? How does this process actually go? And do patients struggle to set realistic goals?
Yeah. Look, goal setting is something I feel I don't do very well with my clients, you know, particularly in the group setting when we bring up skills for behaviour change and we, you know, spell out what a SMART goal is. I can see people's eyes just glazing over and I feel like I've lost them. You know, I guess in the real world, people do set goals throughout their life, but they're not even aware of it. When you start talking about formalising using a SMART goal and those sort of things, a lot of people say to me, I don't want to do that because I'm going to feel like a failure if I don't follow through on it, or the goal that they're trying to set is just too broad. You know, it needs to be broken down into small steps. Like Ali said, a lot of little small changes, you know, are the things that over time will make a big difference in terms of lifestyle management and reducing risk. So, you know, look, we're still trying to help people with personal goal setting. It is definitely something that I revisit with a big focus at the completion of the program. And, you know, that kind of wrap-up assessment to make sure people are on track. And then also looking at who you can refer them to help them on this journey of recovery and staying well. So that can be incorporated in the goal setting discussions as well. So, you know, linking people in with their GP, who's the one that's going to be with them for the long journey, whereas cardiac rehab, as Ali said, is just a short space in time. In terms of recovery, you know, it might not be the right time to be focusing heavily on the goal setting when maybe, you know, the goal is actually getting out of bed every day for a start, or paying the mortgage, you know, or, you know, other conflicting things that are happening in people's lives, because they're, you know, we're all really complex beings. Yeah, so I don't know, I'd be really interested to hear what other clinicians' experiences have been with goal setting. I have had a few clients who have set a goal. One client in particular wanted to do the City to Bay walk. We sat down and worked out some steps along the way that would help that person build their fitness so they were able to successfully complete that goal. And they did that really well. And that was, you know, a great outcome. The other thing that I find is quite powerful is, particularly in the group setting, people sharing what has worked for them in the past, particularly around some lifestyle changes. So sometimes as clinicians, we tend to focus on what the clinical goals are, but if that's not meaningful for that particular person, as Ali said as well, you know, you're not going to get change, and people can say, oh yeah, I am, oh yeah, no, I'm hearing you, but you know, haven't made the change when you see them next, or they still haven't taken steps towards that. So yeah, it's a complex process, definitely.
I mean, it's something as big as running a marathon. I could never imagine setting a goal like that, but then we might ask somebody to go, oh, you have to quit smoking. That is a 2-year process. That isn't going to happen in the course of your cardiac rehab.
Yeah.
Did anyone, yeah?
I was going to say the goals that I set for my patients isn't always clinically orientated. And I suppose Ali,
Claudine, I can't hear you very well.
Sorry, the microphone's not very strong. Oh, thank you.
Around the microphone. I just wanted to share that in my experience with goal setting, I don't always do clinically oriented goals. Sometimes I just ask the patient, or don't ask the patient, I just say to them, what goals do you want to set, whether it be personal or to do with your heart condition or health in general. Because as Ali alluded to, it's that's, I think when you discuss that with the patient at the start, that is what can get them to engage better with what you're trying to do for them. So if their goal is to go to Greece in the summertime, then great, because that's all part of the that motivation to get them going again.
It's not just an abstract, you need to lose 10 kilos.
Yeah,
It's you might want to go to Greece, and so you need to be healthy enough to walk around.
Yeah. So you can work around those more personal goals and work around it from a clinical angle. But I think that's how I, in my experience, how I've been able to establish rapport with that patient right from the get-go. And in a face-to-face setting, Caroline, it is really difficult, you're right. And I used to just ask about some goal setting or goal thinking in the nursing assessment part. You know, do you see your patients? Yes, you do your nursing assessment, then you start in the program. Yeah, that's when I would do it. I'll just say to Joe Smith, you know, do you have any particular goals that you want to achieve as part of this program, or just in life in general? I guess with the cash telephone program, we have the capacity to be able to follow that up at 6 and 12 month review, and that's where I found it difficult in the face-to-face program at the Royal Adelaide, when I didn't have the ability to be able to, or didn't have the resource to be able to follow up on their goals long term.
So it's that follow-up is important for the patient to know that someone's noticed, keeps them on track. I think.
Yeah. And yeah, I think, Claudine, you're right. You know, in terms of that first contact with the patient, it's about building that connection, building relationship, finding out some common ground of their interests and those sort of things. And yes, definitely do that at the first, you know, face-to-face before they either start the group or we go to the, you know, one-on-one sort of side of the program as well. Yeah.
Yeah. And we'll see if we can squeeze in one last one, because you already mentioned it, and Ali mentioned it too, about being referred to a nutritionist, and it sounded like it wasn't a terribly helpful thing for Ali. But that process of referral, like at what point do you start thinking of referral, and what sort of referrals would you offer to a client maybe that's really struggling even with goal setting?
Yeah. So there's a couple of different things in the issue of referrals. So I guess, you know, my first contact, the first face-to-face, maybe over the phone or a virtual assessment, is actually assessing clinical recovery. And, you know, I might even at that stage initiate a referral back to the GP, sometimes even to their cardiologist if there's clinical concerns. And I'm pretty sure everyone out there will be seeing, with the push for early discharge, you know, sometimes people are coming out of hospital and they're still not terribly stable, or they haven't actually got that appropriate specialist care follow-up, you know, happening in a timely manner, or sometimes even not at all. So, you know, that's, I guess, more of an acute early on referral pathway. When we're delivering group cardiac rehab, it's a multi-D program. So we already have, you know, the services of a physiotherapist, pharmacist, dietitian, social worker. Those people are already within the program. But if someone is not getting enough out of that group session with that particular health professional, or they choose not to go down the pathway of doing the group because the group setting's not for them, they might be back at work, other conflicting priorities, then I will do the one-on-one referrals using clinical judgment, which comes into play, you know, pretty much with every interaction with a client, about what additional supports they might benefit from. But I think, you know, key, and we talk a lot to our clients about finding that GP that they feel listens to them, that kind of gets where they're at, that is able to give them the time that they need, because that's so important for the long-term recovery and their secondary prevention and those sort of things. For people who have, you know, either the financial means or they might have private health insurance, we might refer off to further support with an exercise physiologist. We've got connections with, you know, a lot of our local gyms as well, who do special rates for our clients. So once they've completed the group exercise sessions with us, they might want to continue on in the facility that we use, or they might want to go to one of our other community facilities, and we can kind of help all of that to happen as well. Yeah. And 6 and 12-month follow-up is incredibly important. And, you know I don't do it very well. I'm only one person, and I feel often that I'm getting pulled in all these directions. So getting the GPs on board to make sure that there's a chronic disease care plan in place, that there is this ongoing support, I think is incredibly important.
Yeah. Yeah, so because it sounds like Ali said that she could continue with her rehab for 2 years and be comfortable with that. So yeah, I think people do need more than some support after rehab ends. So we just have a couple of minutes left. Did anyone have any questions for Ali or for Caroline before we conclude our session for today? Honestly, yeah, we could have heard a lot more from you guys. It was fascinating. Thank you.
What advice would Ali give herself?
Okay, so from Robin to Ali, what advice would you give yourself now, knowing what you know now?
That's a really difficult question.
Oh yeah, we're just going to finish this off in the last 2 minutes of that.
I think maybe take it a bit more seriously than what I did would be one of the things. you know, there was a lot of things that Carolyn said that really resonated with me, and particularly around having that good connection with your GP. I did have that when I was actually pretty lucky. One of the advice that I would give others would be to really advocate to get a reasonable amount of information about your condition, because the more that you know about the actualities of your condition, the more you're actually going to engage in what you need to do to make yourself better.
Yep.
And I think, things may have changed a bit since I was in hospital. I don't know whether they're still handing out those rather bland.
It sounds like they're getting people out pretty fast still. So yeah.
Look, more information doesn't hurt, and people will consume it over time. I think, you know, whether it's a face-to-face rehab or whether it's phone rehab, I think it's just so worthwhile in taking yourself as a consumer forward, and not feeling alone and uncared for. So I think that part of rehabilitation is really, really important, is to actually have that touchstone of people that know and you don't feel judged by them. That's a really important part of that. So knowing that and having that connection is important.
Fantastic. That's a great answer. Okay, so we will. Sorry.
It's Caroline. Could I just make one comment? Is that around the individual to change? Just an experience I've had is that some people that have been referred to me, first contact, they don't seem interested, but then, you know, they've been referred again, and often it's a little while down the track that they're willing to engage because, you know, obviously their readiness to change or their ability to accept the information has changed. So we should never write anyone off, and we should keep trying to engage with people in cardiac rehab.
Yeah, lots of nodding happening in the room here.
Yeah, I'd agree with that too. I think that's a real key point. And it's part of that shock, I think, that people go through, that's not really acknowledged, that, you know, you are going through a major event in your life, and it is a shock to a person, both physically and mentally, and people recover from that differently.
Okay, so we'll close the session there. Well, thank you very much, Ali. Thank you very much, Caroline, for your time. And anyone who wishes